Greeting, my name is Sahar Mohammed Hisham. I am board certified infectious disease clinical pharmacist, UAE licensed pharmacist infectious disease, and hold my master degree in clinical pharmacy. Today, I will present to you a real life inspired clinical case for educational purpose, focusing on the management for complicated urinary tract infection and urosepsis in the patient with chronic kidney disease. In this case, I will focus on the management for complicated urinary tract infection and urosepsis in elderly patient who has chronic kidney disease. We will review the initial presentation, how we conduct an empirical therapy, hospital, how can we use hospital antibiogram data, and stepwise intervention that optimize antibiotic use according to 2025 updated UTI guidelines for IDSA as well as 2024 guidelines for the management of resistance in gram-negative bacteria. Here, I will illustrate our case. This is Mr. AM, a 67 years old man admitted on July 2025. Initially, for the management of stroke, he has a height of 170 centimeter and weight for 85 kilogram. At this time, for admission, he had an indwelling urinary catheter. This was important because urinary catheters are a well-known risk factor for catheter-associated urinary tract infection. 4 days later, after admission, he has developed fever, chills, confusion. His SOFA score increased by 4 points, which is significant and met the criteria for urosepsis. Here I will show you the SOFA score, which is sequential organ failure assessment score, and it is used for the assessment for the extent of the patient organ dysfunction in the ICU setting. It will evaluate 6 organ systems: respiration, coagulation, liver, cardiovascular, central nervous system, and kidneys. Each kidney is scored from 0 to 4, with the higher score indicating more severe dysfunction. A change of 2 points or more in the SOFA score suggesting that the organ dysfunction, that the patient is experienced organ dysfunction, and it is a part for definition for the sepsis according to the sepsis criteria. In our patient, the SOFA score has been increased by 4 points after 4 days of admission, confirming the diagnosis for sepsis, justifying an urgent need for antibiotic starting and the management of sepsis. So the physician initially ordered levofloxacin 750 milligram IV once daily and paracetamol 1 gram Q6-hour PRN when required to control the fever, and also the IV fluid for hydration and management of sepsis. Here, the choice for levofloxacin as a fluoroquinolone used for urinary tract infection, maybe it's a correct choice, and maybe there is a several concern regarding this choice. First, due to the presence of urosepsis, we should rely on our hospital antibiogram if available before taking the decision whether or not we will start levofloxacin. Second, the patient has no prior culture results to confirm susceptibility, making empirical fluoroquinolones risky and maybe resistant. Therefore, the key question is which antibiotic choice would be effective for this patient, considering the CKD local resistance pattern and severity of illness. Okay. As a review for the four-step approach for selecting antibiotic in complicated urinary tract infection and other serious gram-negative infection, the idea is to take a structured approach rather than jumping on using broad-spectrum antibiotic. The step number 1 is needed, and it's very important because it depends on it relies on the assessment for the severity of illness. Our patient has sepsis, as his SOFA score has been increased to by 4 points, but he was not in shock as his blood pressure is not low and there is no need for initiating vasopressor, as well as the patient lactate level is normal. So we can go to the step number 2, which is check the risk factor for resistance. Consider the recent antibiotic use, recent hospitalization, prior colonization for resistant organism, or if the patient is being admitted in the resistance pattern or in the area with high resistant pattern. Step number 4, considering patient-specific risk factor, which include allergies, renal function, site of infection, and whether the patient can take oral drugs or not. Usually we use the oral route only for the stable non-septic patient due to the fact that the septic patient usually has a GIT compromisation, so it's better to use IV option rather than oral option. Step number 4, we must use the local antibiogram if present, especially this because this patient in sepsis. With shock, we usually use the antibiotic with the local susceptibility of more than 90%, as mentioned in the footnote. But if the patient has shock, we must use the antibiotics with susceptibility more than 90%. We go through all these steps in order to maximize our chance to choose an effective early therapy. This table shows our local susceptibility data, the antibiogram for urinary pathogen. This is a key when applying to the 4-step approach because the antibiotic selection in the sepsis rely on the local antibiogram to ensure high likelihood for coverage. Since the patient has a sepsis without shock, so we select any antibiotic with more than 80% susceptibility according to this antibiogram. In this table, for example, we show that it has been appeared that fosfomycin show susceptibility more than 90%. Okay, but it is only available as an oral option in my country, so it's not appropriate to be used for sepsis. Also, the oral fosfomycin is not indicated for complicated UTI. Then, as we see for the nitrofurantoin susceptibility for E. coli is 84%. Okay, as we see, again, nitrofurantoin, its susceptibility is more than 80%. Yes, it can be used according to the antibiogram, but again, the nitrofurantoin is an oral option, so it is not used for sepsis. Then we can jump for the meropenem. It's 100%. It's used. It's available in IV form. Okay, so it's available in the IV form. So we can use the meropenem. Okay, because it's it's in the IV form, and also it's an excellent option for the sepsis. Okay, due to its susceptibility is 100%. Okay. Also, we can go to the amikacin. It's 94%. 94% is more than 80%, so it can be considered as an option for the treatment of UTI. But as we know that amikacin is usually not preferred in the sepsis to be used alone, and the beta-lactam will be much better option due to its safety profile, as also because this patient has chronic kidney disease, so amikacin will not be appropriate choice. So its better coverage and safer toxicity profile will be the meropenem. The other options, which is fluoroquinolones and third generation cephalosporin, cannot be used because their susceptibility is very low. They are less than 80%, so we cannot rely or use them as an option for this patient. So our intervention, the first intervention is to optimize the empirical therapy. Okay, so first of all, this patient is TKD, so we need to calculate the creatinine clearance. After calculation, the creatinine clearance, it showed that it's 37.1 ml per minute. So this low creatinine clearance will require us to adjust the doses for many antibiotics. So we would recommend to discontinue the fluoroquinolones and to recommend to escalate to meropenem 2 grams IV every 12 hours, infused over 3 hours. If feasible, to increase or to maximize the pharmacodynamic parameters with follow-upping the kidney function, and also to add stress ulcer prophylaxis, which is pantoprazole 40 milligram IV every 24 hours. And it's very important to use stress ulcer prophylaxis for this patient, as according to the recent guidelines for the stress ulcer prophylaxis, Usually, the patient that has sepsis with use of antiplatelets as a part for stroke management, usually those patient has two minor factor requiring us to start for them stress ulcer prophylaxis. Also, this patient will need to start the DVT prophylaxis because according to the recent guidelines, we need to start DVT prophylaxis for as a routine for all ICU patients, especially this patient is admitted with sepsis. All these recommendations are being accepted with the primary team, and the patient has been shifted from levofloxacin to meropenem. Stress ulcer and DVT prophylaxis are being added, and also the kidney function has been requested. Why we use the meropenem 2-gram IV every 12 hours and we not rely on this table, which illustrate that the meropenem dose should be 1 gram every 8 hours. Okay. Because as we know from the local antibiogram, the prevalence for the ESBL producing organism is more than 80%. So the E. coli show 22% resistance to the ertapenem. Okay, more than 2% resistance. Okay, because as we see, the sensitivity was, as we see, the sensitivity was 78%. Okay, so according to the definition for ESBL, the ESBL rates is very high. So this resistant level makes ertapenem less reliable choice as an empiric therapy in this patient. According to the IDCA dosing recommendation for infections other than uncomplicated cystitis, okay, for all other infections regarding the resistance pattern, the dose should be 2 grams IV every 8 hours infused over 3 hours if feasible. This is for the patient with normal kidney function, but for our patient, we must adjust the dose to be taken every 12 hours. This higher doses and extended infusion optimize the MIC, which is critical for treating the ESBL organism, especially for this septic patient. The second intervention is after the culture reviewing and the potential for de-escalation, which is after 48 hours from starting of the meropenem. The patient is still febrile, but his mental status has been improving, and other infection markers like white blood cells and hemodynamics and CRP are being improving. Has been improved. The urine culture show ESBL producing E. coli susceptible to the ertapenem, fosfomycin, meropenem, trimethoprim, sulfamethoxazole. So the decision is to de-escalate or not. The decision is to de-escalate the meropenem to ertapenem 1 gram IV every 24 hours. The rationale behind this shifting is that we does not have any pseudomonas. We do not have any pseudomonas. Okay, so no need for pseudomonas coverage. Also, the ertapenem offer a narrow spectrum, but it's still reliable for coverage for ESBL. This approach will align for the antimicrobial stewardship principles and improving the targeted therapy and reducing the risk for resistance. As we see that the persistence for the fever alone is not a contraindication for narrowing therapy. Okay, if the patient is clinically improving, the fever may be due to other factors such as inflammatory response, drug effects, or non-infectious causes. So all the markers are go to the side that this patient is improving. So we will go for the concept that we need to de-escalate. Why not shifting to trimethoprim or fosfomycin as an oral option? Because again, this patient still have fever. Okay, so we cannot neglect that maybe there is the sepsis is still present, so we cannot shift to the oral option like fosfomycin or trimethoprim. And again, fosfomycin is not used for the complicated UTI or sepsis, and trimethoprim sulfamethoxazole, we should not go for this oral option except if the patient has been show full clinical stabilization. The patient condition after 2 days, 48 hours after switching from meropenem to ertapenem, the patient condition has been improved significantly. He become afebrile, no chills, and the mental state returned closer to the baseline. This clinical improvement confirmed our de-escalation decision that was appropriate, and the ertapenem provide an effective targeted coverage for the ESBL E. coli isolated from the urine culture. Then, according to the IV to oral switch pathways for the complicated UTI, according to this patient, this placed the patient on clinically improved branch, this part. So the next step is to assess the appropriateness for the oral option based on the culture results. In this case, both trimethoprim, sulfamethoxazole, and fosfomycin are susceptible. Since the patient is no longer septic and has a complicated UTI, this patient has no contraindication to the trimethoprim sulfamethoxazole. Switching to oral trimethoprim sulfamethoxazole is the most suitable option. This will allow us to complete the course, which is 7 days, because the patient show an early clinical improvement. So it's effective to target oral therapy, supporting antimicrobial stewardship and facilitating discharge plan. In this slide, I will summarize the whole case journey from the empirical therapy to targeted treatment and finally switching to oral therapy. We started with IV meropenem because the patient is presented with sepsis, and our local antibiogram show very high ESBL prevalence above 80%. Once the urine culture come back, it's confirmed for ESBL E. coli that was showed sensitive to ertapenem, fosfomycin, meropenem, trimethoprim, sulfamethoxazole. At that point, we were able to de-escalate from meropenem to ertapenem, which is narrower spectrum, but still effective against the isolated organism. After 48 hours on the ertapenem, the patient shows clear improvement. The patient become afebrile, no chills, and the mental status become back to normal or close to the back to the basal line. Following the UTI protocol, the IV to oral switch guidelines, this placed the patient on clinically improving branch. So we will evaluate it and choose to switch to oral option. Both fosfomycin and trimethoprim sulfamethoxazole were susceptible, but fosfomycin is more suitable for uncomplicated cystitis, so we select trimethoprim as an oral option. This allows us to continue effective targeted therapy, support antimicrobial stewardship, and plan for early discharge. The third intervention is to determine the most appropriate duration. So since the patient is eligible for the oral treatment and we shift to the oral trimethoprim sulfamethoxazole, so we choose to prescribe, we choose the patient complete his duration on sulfamethoxazole trimethoprim, one double strand tablet twice daily. There is no dose adjustment is required because the creatinine clearance was above 30 milli per minute. We will choose to complete the total for total extra 3 days because the patient is already started on IV treatment for 4 days to complete the whole duration with 7 days. Finally, those are my references, which is 2025 updated guidelines for complicated urinary tract infection, 2024 IDC guidelines for the management for antimicrobial resistant in gram-negative bacteria, lexicon for drug dosing information. And I'm encouraging you to take the full review for these guidelines. I make already a video discussing all the recommendation, and also I use the 2024 guidelines for stress ulcer prophylaxis and 2018 ESH guidelines for DVT prophylaxis in the ICU patients. Thank you for your attention, and thank you for your participation. I hope the case could be helpful for you. Wish you good luck. Thank you. Goodbye.